So I would now like to invite Kerri to speak.
Kia ora koutou katoa, ko waio, ko manga haruru, ko taki te mutu waka, ko Ngāti Kahanunu te iwi, ko Ngāti Tū te hapu, ko Tangoe o te marae, ko Kerri Nuku, toko ingoa he kai whakahaere tōputanga tāpuhi kai te aki o Aotearoa, the New Zealand Nurses Organisation. So I am the kai whakahaere, and in our organisation it reflects a tangata treaty framework. So we have a president and a kai whakahaere, myself, that work equally in providing governorship across the 56,000 members, or 65,000 members, sorry, that are a part of our organisation. And as you'd probably seen, we've been in the media quite a lot because what we've currently got is a government that refuses to respond to the needs of our changing health dynamics and population demand, but insists on pressing down on these financial austerities. And so what we have is a system that is underfunded, has been for many years, which is causing problems around workforce. This government fails to recognise the ongoing understaffing of the system, and therefore perpetuating the actions or unsafe care. So it's been, our organisation has responded in a way by challenging the system, by having these continuous strikes. That's what we're most known for, I think, in the recent weeks. But, you know, to be real here, we've had a system that's been underfunded for a long time. Prior to COVID, all our members, especially those members that work within the health system, were raising concerns about the lack of staff recruitment and our ability to retain. So moving into COVID, it highlighted the inequities and the understaffing that existed. And even though many of our nurses did the very best they could in really challenging times, once we got out of COVID, there was no redress, there was no pause, there was no recruitment, there was nothing. So many of these nurses have been running on empty since 2020 and continue to do exactly that. So this increase in unsafe staffing is reflected in the data that Te Whatu Ora themselves hold, which shows a significant understaffing of the hospital wards. But the question that I was asked is specifically around what does the current health system look like on Māori health and Māori health outcomes and nursing experience. So I'll shift to talk about specifically that. Well, it's very clear to see our organisation has been challenging this government particularly ever since there was the removal of smoke-free or review of the smoke-free legislation, which our people die of tobacco-related diseases, have continued to and will continue to die of tobacco-related infections if we don't proactively do something. But, you know, even though that came out from this government in their 100-day plan, it quickly preceded the discussion around the Treaty Principles Bill and its removal, and then the Regulatory Standards Bill. Submission and bill after bill was intentionally eroding the voices of nurses, or the voices of Māori, sorry, within the health system. And why this became really incredibly important is because we know that Māori are overrepresented in poor health outcomes. It will continue to do that. And even though this government fails to recognise or talk about inequities or reducing inequities or removing commitment to Te Tiriti of Waitangi from their principles, statements and plans, it's just disguising the fact that our people will continue to die at a faster rate behind closed doors. So our organisation has been proactive in challenging the government tirelessly. around trying to keep the voices of Māori and Māori health active within the policies that they continue to produce, and should I say bad policies that they continue to produce. Just because you write somebody out or silence them doesn't mean to say that we've healed ourselves or we're fixing the problem. It just means that when some government has the courage to start to look at and monitor health inequities or the impact of health on ethnic groups, we'll see that population would have increased in terms of the level of deaths that are currently happening out there that are preventable. So notwithstanding the fact, we've seen many Māori and iwi providers stand up, which is abysmal given that they're trying to do the best that they possibly can with significantly less money and to be able to do the services that they currently do. The money that they receive in terms of Māori and iwi providers is significantly less than what is required to actually do a meaningful job. Yeah, the nursing experience, many of our nurses that work within the system are currently burnt out, tired and fatigued. We have incredibly large amounts of nurses that have given up trying to work in Aotearoa, New Zealand, especially when we've got new graduates, and this government over the last 2 years has only employed less than 50% of those new graduates. The other new graduates are looking to go overseas where they can get employment. And that seems to be Australia is the closest place for them to go, where they can still be connected with their families. Many of the nurses that are leaving are going for better job opportunities. New graduates are getting placements. They're getting supported to relocate to Australia. They're working within areas where safe nurse to patient ratios are implemented. So the demand and pressures of them working within many of those health systems are a lot less than what they'd get here. So we've got nurses at the moment that are at breaking point. And the unfortunate thing about that is that the voices for nurses seem to be silenced across much of the system. And many of the nurses that have taken the courage to try and stand up and advocate for patients, unfortunately, are either being threatened with job loss or are pressured or demoted if there is any and not supported within their workplace. So it's a really difficult time to be Māori. It's a really difficult time to be a nurse. And it's incredibly challenging to be a Māori nurse that's currently working within the system, trying to uphold the mana of their culture and represent the views and aspirations of their patients, particularly Māori. So going back to what this is in a nutshell, and I was talking to a couple of nurses today, and we were talking about this panel, and they said, if we can get if we can get New Zealanders to get behind a system that is publicly funded, that doesn't recognise or judge people by the colour of their skin, but will take people on, and that we can have a service that is responsive to the needs of all different cultures, that is accessible, and that means not just culturally accessible, but financially accessible, that is easy for us to get to, then that is all that we require, right? That's all that we should expect as a health system to respond to the needs of its community that it serves. But when you get charged in primary healthcare up to $100 to go in and access a service, then it makes you think twice about whether or not that $100 could be used somewhere else. And when you're the nurse that knows that you're prescribing a medication to somebody, when you know that they're the ones that are questioning whether or not they should be there, or does that extra additional $10 to get a prescription, is it going to break the bank for people? Is it a matter between putting the loaf of bread on the table at night, or the nurses are often the ones that will jump in their car after work and go down and get the prescription filled, because ethically and morally, they're the ones at the bedsides that are making those really critical decisions. And it's really hard when you go into nursing to care for people, but the system doesn't allow you to do that. Kia ora.
Kia ora, Kerri. I really appreciate all the work that that you and nurses do for us in New Zealand. We'll have time for questions at the end. So our next speaker is Tim. Welcome, Tim.
Kia ora koutou. Just a moment. Just checking you can see. I have a presentation and just checking that that is visible. Okay.
Not yet, Tim. We
Not
can't
yet?
see the presentation. I don't think you've shared your screen yet.
Yeah, I thought I had. Okay, let's try it again. Sorry about that. Thought we had this all sorted. Share that one, and we're good. Wrong one. Sorry. How's this one? Are you seeing a PowerPoint slide?
Yes.
Yeah, we just need you to go into
I'll go into
presentation mode.
mode.
Yeah,
Yeah.
perfect.
Good.
Thanks, Tim.
Right. Okay. So kia ora koutou. Thank you for the opportunity to present at this session called Tenbensel. I didn't mean my biography to be so long earlier, so most of that you can forget about, please. But I think I'm going to talk today about a report that Professor Paula Norgelli and I were commissioned to write by the ASMS. And it's because a number of us throughout last year were had noticed the figures that were published on the Ministry of Health's website about the level of health expenditure in New Zealand, and we thought there is something wrong here. This cannot be right. And many people were thinking in the same direction. So the ASMS got in touch with us and said, "You want to do a brief on this?" Which we're very happy to do. It was a bit of a journey, and the two questions that we were asked to explore, I think really go back to what Kerri was talking about earlier. Firstly, some questions about how our health system is financed, what are the advantages and disadvantages, and the key question of how does our level of health expenditure compare historically to other countries. And this is important, although we know that there is a general feeling in the sector of underfunding, as Kerri has eloquently put forward that case. We do need to be able to support that when if challenged by governments or ministers who say that it's fake news. So now, so what we started with is the question about the different ways of financing a health system, and I think this is important because we have a tax-funded system. It's not the only possible way of doing it. What is really important is the balance between public and private funding or financing, because the more private financing, the more likely there are inequities, and also the less efficient and less value for money a health system is. We know that we've known that for a long time. But for publicly mandated financing, there are different ways of doing it. We can do it through tax, or we can do it through something called mandatory insurance, of which ACC is an example. We have a combination, but our system in Aotearoa is predominantly tax-based. Within tax, you can just use general taxation as we do, or you can have a dedicated or hypothecated tax. We discussed that in the report. I'm not going to talk about that too much today. And there are different ways of doing mandatory insurance depending on whether there's one insurer or multiple insurers. And you can see here in the second line the broad breakdown of who pays for what, or what percentage of the health system. And those figures are remarkably stable historically. So I'm not going to talk about public versus private. We're going to talk about within publicly mandated systems, what are the pros and cons of a tax-based system versus a mandatory insurance-based system. And I'm not going to go through all these, but I think the general consensus, we did an extensive literature review, is that tax marginally comes out on top. It does have weaknesses. It is more volatile, as you know, the peaks are higher, the troughs are lower. It'd be like in increases or decreases in expenditure over the years, but over the long term, it's has more advantages. Delivers pretty similar benefits, and it does them for less cost compared to a mandatory insurance system. Happy if you're interested in that and you have questions about it. So broadly speaking, a large part of our report is to say why tax-based financing is right, or why it doesn't make sense to change it, as some have been arguing, to something that's more an insurance-based ACC type system. And you know, health financing is something that's very difficult to change, and countries very rarely do it. So we think that debate is, well, while it's an interesting one to have academically, practically we don't see much point in going in that direction. Then comes the question of comparing our expenditure, and so the question is, who to compare with and what to compare. So the what to compare is really a combination of two things. One is our health expenditure as a percentage of GDP, and we know there's lots of problems with GDP as a measure, but the problems are the same everywhere, so we are doing something that is comparable. And we want to look at total health spending and publicly mandated health spending. And we also want to look at the actual amount in dollars and compare that internationally as well, because we have a smaller economy, we're lower GDP per capita, whatever that means, but it does reflect some real issues there. So in some sense, we might not be able to afford as much as countries with stronger economies, but we do need to keep track of how the actual money that is spent and how that compares. So neither of those two measures are perfect, but they do tend to balance each other out. The 16 countries we compare ourselves to might be a little bit hard for you to read, but we needed to use OECD data. That was really the only comparable database that there is. We wanted to exclude countries on the basis of those with really high GDP per capita and those with really low GDP per capita within the OECD. So we ended up with 16. Now, some judgment calls there, and you can see our logic there if you're interested and you want to ask us about it. But these were the countries we ended up with. You'll see those in a moment. So, just briefly, no need to sort of take in everything in this slide, but I mentioned that New Zealand, Aotearoa New Zealand spends roughly 80%, or 80% of all that is spent on health is spent through tax or ACC, okay? That figure is fairly comparable to most of these other countries where that figure is between 70 and 85%. I'm saying don't worry about the 2022 figures, and I'll explain why in a moment. But when we were doing this analysis, we thought it would be fairly straightforward. We knew there would be some problems, but there were a number of problems that were discovered in the process. And the first problem is that New Zealand has not, our Ministry of Health has not submitted data since 2018. We're the only country not to do this, which is appalling, because how can we actually have an understanding of where we sit comparatively if we don't have the data to do it in the only way that is generally recognised to do it. A second problem, which our colleagues at the ASMS actually uncovered, is that when we do report on health data, it includes a GST component, which is fine in one sense if we want to compare public and private. But if we want to compare New Zealand with other countries, it's a problem because there's a GST component applied to our tax-based health expenditure, which is totally fictional. And we don't know to what extent that affects the figures. That's an open question. But the result is that even on the existing figures, they're likely consistently overestimated and have been for a very long time. And the third problem that we found was the timing of COVID and when COVID expenditure hit our health sector was later than other countries. And that really affected the comparability. The figures the ministry was using from 2022 were from 2022. That was the worst possible year to try and compare our spending with other countries due to the timing of COVID. So we have a very misleading recent picture from OECD data, and it's not to be taken at face value. We tried to do some re-estimates because there was also overestimate of ACC expenditure, and these are the figures, and you can look into the report for the details. But the overestimates basically amount to about $2.5 billion in 2023. So this is not trivial. Here's an overview of how things look over the long term and how this picture emerged. So the light blue figure is the one this is publicly mandated health expenditure, and the light blue is New Zealand, and this is how we have been falling behind from about 2012, 2013 onwards. Our conclusions and recommendations are that tax-based financing is sound. We've had a decade of comparative underfunding already from a low base. If we're talking about how much is spent per capita, the 2022 budget was a significant boost, but that partly addressed delayed spending and was not a sustained catch-up. There's UK analysis that suggests that that figure currently at 8 or below 8% of GDP needs to rise to between 9 or 10% to address demographic and epidemiological trends, not to mention equity and unmet need. So our urgent recommendations are for the ministry to resume submitting this data and to withdraw any claims of overestimating the amount that we spend. So I'll leave it there. I'm happy to answer any questions that might come up a bit later. Thank you.
Kia ora, thank you, Tim. So don't forget, people, questions in the chat. Our last speaker I'll hand over to now is Harriet.
Kia ora koutou. Thank you, Lisa, and thank you to Kerri and to Tim for your presentations as well. I've got a presentation too. I will just share my screen and hopefully you can all see that one. So my name is Harriet, and I am the Director of Policy and Research at ASMS. ASMS Toi Mata Hauora is the union for senior doctors and dentists in New Zealand. The majority of our members are employed in the hospital and in the public hospital system with Te Whatu Ora. Our constitution also mandates that we advocate for the best possible public health system for Aotearoa New Zealand, and that is where a lot of our research and policy effort is put in, as well as ensuring that our members have the best possible terms and conditions available to them. And let me just go to our next slide. So we know that the impact of social determinants is really inextricably linked to the health outcomes from our health system, and this diagram is one that I've adapted from one from Diana Safati and Bridget Robson, which was based on cancer, but really I've sought to expand it. So you can see how those determinants, protective factors for illness and disease, the healthcare system and outcomes are all inextricably linked. And there's an overarching context of, social, political, economic, cultural intersections, the impacts of racism, colonisation, ableism, and gender-based discrimination really intersecting together to create the outcomes that we see in the system. So I'm going to take you through some of the findings in one of our recent papers in the same series as the paper that we commissioned from Tim and Paula. This paper looks at some of the consequences of that underfunding in the health system and what it means for the health of New Zealanders. So this is a recent report that we've put out called Managed Decline. And that looks in the decline in good health and the corresponding rise in not good health. Because the report's author, my colleague Andrea Black, is an economist, she's also put some numbers around that, which is quite illuminating, and it looks at what that decline is costing us. So the report considers the self-rated health question in the New Zealand Health Survey, which has been run by the Ministry of Health annually since 2011. And since that time, 2011 through 2024, there has been a marked decrease in the number of people reporting to be in good, very good, or excellent health, and a corresponding increase in people in not good health. So excellent health, which would meet the World Health Organization's definition of being in a total state of physical and mental well-being, has seen a 45% decline for people under 65 and a 25% decline for people over 65. Fair health has seen a 54% increase for people under 65, while for people over 65, it was broadly unchanged over that time. What does this mean? Well, it means that this increase in fair health is most pronounced in people of working age. And that's really important because those people are our taxpayers. They're paying for the health system, which we're underfunding at the moment. And within that working age population, there are some really pronounced inequities. So we are seeing that the rise in fair health is disproportionately affecting women, Māori and Pacific peoples, with Māori and Pacific women the most affected and impacted by the increase in fair health. And we can see that these changes are really driven by the impact of the social determinants of health in the previous slide. So this infographic on the left here, we know that health happens outside the health system. This infographic is taken from the final report of the Health and Disability System Review, the Heather Simpson Review, which, if you remember, the original terms of reference had the social determinants out of scope. So they were told very strongly at the time that no, any review of the New Zealand's health and disability system has to account for the social determinants. So it was good to see that this infographic was included in that final report. So less than 20% of a person's overall health is determined by clinical care. The socioeconomic, environmental and behavioural factors are much more influential. And two of the most pronounced changes in the New Zealand Health Survey since its inception in 2011 is the increase in the prevalence of overweight and obesity, but also the rate of psychological distress. And that figure below shows the rate of high and very high psychological distress in the last 4 weeks by age band. So, the 15 to 64 age group, which is the working age population, which are most affected. And you can see that really quite astronomical rise after or during and since COVID. So with Andrea being an economist, she was able to use the Treasury's CBACS tool, which estimates costs, including social costs for various interventions, and we put the cost and the decline in health at between $2.6 to $8.6 billion annually, depending on the parameters used. So it changes depending on whether or not you're including fair health, whether that's the decline in excellent health only, including physical health, or physical plus psychological health. There are also really important economic costs. So this government loves to talk about productivity. Well, with the increase in fair health, there is a $1.9 billion reduced output, and also a presenteeism cost as well. So the costs are not insignificant to the increase in fair health that we're seeing. And of course, at the same time, access is worsening. And this chart here shows the increase in unmet need for a general practitioner due to wait time. And you can see that there is, again, a highly inequitable experience of that unmet need for a general practitioner due to wait time. So for wahine Māori and for Pacific women, that has really taken off in a rather exponential way. And just in the times in the last few years. And aligned with this, but not wholly related, I think understanding this relationship is really important when we look at health and we look at access to services. Demand on emergency departments is increasing, but people aren't going to EDs because they can't get a GP appointment. They're going to ED because they feel they're unwell. And I think that's really important to underscore and to recognise, because the idea that people are showing up at the ED and EDs are becoming really overcrowded because people can't afford to go to a GP, it's not really borne out by the data. And there have been some really great studies, particularly at Middlemore, that show that people are going to ED because they feel they're unwell. And when we talk to our members, which include ED doctors, they say, no, these people need to be at emergency departments. They do need hospital level care. So we're also seeing that increase in the triage numbers. So those most urgent triages that need to be seen really within 30 minutes, those are increasing. And by 2023, we saw that there were more than 2/3 of ED presentations overall meeting that triage 1 to 3 level. And as a kind of thought experiment, we cast forward to see, well, if trends continue, what are we looking like in 2035, 36? And if we do nothing, we will have fewer than 7% of New Zealanders in quote unquote excellent health. And that is, that should be a cause of great concern. And that would mean that nearly 20% of New Zealanders, and with population projections likely well over 1 million people, being in fair or poor health. People in fair or poor health need more health services. There's no way to know as well if the current proportion in poor health, if that is to continue at the same trend. It's been fairly static over the reporting period, and whether or not that would continue to reflect into the future. I think when you're looking at this, at these sorts of projections, it's also really important to recognise that with the way that the health survey has run, that 2011 was by no means like our best year for health ever. It's not our high watermark. It's simply when the health survey started. So it's our baseline, but we're looking at trends over that period. It's not considering or taking a mark as to saying, no, that our health as a nation was the best then. In terms of the costs associated with these continuing trends, the monetised social cost would be 3.3 billion per year, on top of the original estimate of around about 3.6 billion, depending on which parameters you use, per year from 2011, 2012 through to 23, 24. So there's really important implications of underfunding the system. I'd like to give a tautoko to Kerri's point about the health workforce as well. The health of the health workforce is critical to ensuring the continued operation of the system. And while we have consistently had pretty good outcomes considering how poorly we do fund health, according to the Tim and Paula report, a lot of that extra effort is simply on the goodwill and the volunteer work from our health workforce. So that's, again, a really important to reiterate to you as we campaign for a better healthcare system, for better outcomes for New Zealanders. Kia ora.
Kia ora. Thank you, Harriet. So we have a little time now for questions, and we have some pretty long questions in the chat here. I thought I'd start with, since you went first, Kerri, someone had a quick question here saying they'd heard that new nursing grads who are now getting offers as nurses are only being offered 0.6 FTE roles. Is that true?
Unfortunately, that's true. That's not, this was adopted. Australia started to look at this, adopt it. And so this is what New Zealand chief nurses have supported its implementation. Now, that goes against the grain with everything that we believe, because these new graduates graduate with a $40,000 loan. This is not enough to give them the experience in the workplace, but also many of them are looking at taking second jobs to be able to be financially sustainable. So this is not a clever idea. This is not what we mean by recruitment. And this is the problem that we've had, is governments have failed to develop a comprehensive future-focused workforce strategy. Even though we know that we've got a lot of nurses that were due to retire, we've got this increasing systems, increasing health demands, but the workforce has not planned for this. And given that we've got, as I said before, over 50% of the nurses that didn't get jobs in Te Whatu, we've got significant issues, but this is not a viable alternative. This is absolutely not, but it is a true feature that is happening.
Just asked to further that, at 0.6 of an FTE, is your graduate nurse earning the minimum, a living wage?
They are, but they've got the burden of financial burden, and this is not enough to be able to keep paying that, as well as we've got increasing cost of living. So, we've got huge burdens on them already. And there is an expectation that they have to do so much professional development or theory or practice as part of their transition to practice year. There is education commitments on them as well.
And are they ever required to, work beyond their paid hours?
Oh, yeah. When the system, this is the problem with the system at the moment. We've got nurses, and the data from Te Whatu even says that, especially in some of our high risk ED places, over 90% of those that are not fully staffed, and that's the data that we've got. So many of the nurses will feel anxious because they don't know whether they're going on to a full complement of staff or not. But what we can guarantee is that wards are heavy. And many of the times when we do not have senior staff, these young ones are expected to step up. They're being paid by the system. They're expected to take more and more. The risk for them is they would start to work outside of their scope of practice, and then we run into a whole series of problems. But the system is forcing them to work further and further outside of their capabilities. And the minute you start to get them saying, oh no, this is not what I can do, then actually after a year, they may not get offered a placement, or after that, it starts to become part of that vicious cycle.
Oh, where? Thank you. Well, the next question here goes to all of you, from Kate Stone. Do any of you know to what extent the Ministry of Health takes into account long-term costs and benefits, both economic and social, when modelling the cost of policy choices?
I'm going to throw that one to Harriet first off, and then if that's all right, Harriet.
The short answer is yes, they do. And I think, when we have been looking, particularly with managed decline and the results of the New Zealand Health Survey, Treasury and the Ministry are really interested in these results and the decline in good health. So while there is a spin put on the results every year, and it will say, I can guarantee you, in a couple of weeks when the latest results come out, the majority of New Zealanders are in good health. There will be people that are looking at that decline. And we have sent our report around all the traps, as you would expect. So yes, people are looking at this, and as part of things around regulatory impact statements and things like that, the cost, both social, fiscal, etc., is considered as part of policy choices, absolutely.
Perhaps the more accurate, or the better question would be, to what extent is the Minister of Health taking into account that policy modelling?
Well, yeah, that's right. It's hard to say, right?
Yeah.
And a range of advice is provided. We access some of it through the Official Information Act. Some of that advice is redacted under free and frank guidance from the ministry. So it's not always clear what has been provided and what is being taken on board. But you can guarantee that anything that involves a dollar figure is heavily scrutinised by Treasury in particular.
I have a question here from Teresa Homan, which I don't really understand, and you might want to clarify it in the question. It asks, why not tax personal KiwiSaver contribution for health funding? Investing in health and retirement by healthier people retiring. I was just wondering, are you suggesting that if we tax our KiwiSaver a bit more to fund better healthcare or health promotion, then people won't need so much money in retirement because they're going to be healthier? I'll let you answer that while I ask the next question, because I think it's an interesting idea to explore. So we have a question here from Luke, and it's quite a technical question, so this might be one for Tim here, although it relates to your work, Harriet. So could scrapping the bottom tax bracket, introducing a mid-range 22% bracket and adding new brackets for those earning over 450,000 and 1 million help to ensure that those on low to middle incomes have more disposable income, a more livable income, enough to buy good food and have better work-life balance, access to justice and education, etc.? And goes on, could restructuring corporate tax to a tiered system that relieves tax burden on small, medium-sized enterprises but increases the tax on big multinationals allow for additional tax revenue, and to use that for expenditure on health and education?
Okay, so I'm not a tax expert by any means. I'm not an economist. So I think as far as we can go is to say, well, more needs to be spent. How do you get that? You need to tax more in some way. How to do that? I'll leave that for other people. It's outside my...
perhaps that's more of a question for our audience here today. Like Gail might be able to put an answer in the question for you there, Luke.
But I'm happy to, sorry, Lisa, if I'm just happy to sort of address one thing that does come up in this context, which is having a hypothecated tax. I know I mentioned it, sort of a dedicated tax that's dedicated to be spent on health. And there was a big debate on this, similar debate 6-7 years ago in the UK. And, you can see from a health point of view, this could be, easier to sell a tax increase that was dedicated directly for health, and to some extent that's sort of what Labor did last week. There are some benefits for the health sector in doing this. I'm not sure whether it's a good idea overall, however, because the question is either if you do it partly, then still most of your funding for health comes from general revenue, so you're not necessarily dealing with the main issue. So it's tend to be regarded as a fudge and window dressing if you do it, like the Australian Medicare levy is. Is funding that goes to health, but in no way it funds the whole health system. If you do it totally, then you might insulate health and protect health spending, but at the expense of what? Well, probably education, social welfare, and other things.
And just to add to that, I think we've seen some really interesting projections related to the decline, for an increase in health spending, which is inevitable with an ageing and growing population, at the expense of other sectors, and education is one. So the Treasury's recent long-term insights briefing does touch on that, and there are some really fascinating graphs that do show over time a projected decline in education spend and a much higher spend in health, driven by our population's needs. So but also just a general point that many taxes are regressive and do impact disproportionately on lower income people, and there are some really important inequities that need to be considered with the application of any tax change.
I think there's just time for one more question here, and this one is directed at Tim and Harriet, but I'm sure you might have something to say too, Kerri. Do you have an estimate of the government funding of health as a percentage of GDP that would be considered adequate in some sense? Bearing in mind, I guess, of course, that we're very good at doing what we do with the money that we have.
Yeah. Well, we don't on New Zealand data and New Zealand conditions. In fact, I don't know many countries that would do an estimate of that, but one country that has is the UK, and they did it fairly recently, and we talk about it in our report. And their conditions and history is actually quite similar to ours in terms of the pattern of health expenditure. And that report by Anita Charlesworth and colleagues recommends, that's the one that sort of says that it would need to be for the UK between 9 and 10% by 2033. 9% is just delivering sort of business as usual. 10% is actually addressing the unmet need and sort of dealing with the epidemiological trends and chronic diseases and things like that. So that's quite a considerable increase from where we are now, if we were to apply that. But of course, if we were to apply it, and I think we're making the case that similar analysis needs to be done here.
Yeah, and just to build on that, Bill, I think you've put in your question really that it's less so in comparison with OECD countries, but we need to understand unmet need in this country. We do not. We have no idea. We do not count it. We do not measure it in any meaningful way, consistently with inequity in mind. So I think we need to understand unmet need, and we also need to understand the workforce that is required to meet that need, and then we'll be in a much stronger position to understand the funding that we need to fund the health system equitably.
But also, I think I could add to that, it's not an easy thing to do.
Fantastic. I just wanted to take liberties to ask one little question I had, and if you could answer it really quickly because we have to finish. But do we have figures on, say, age-adjusted health expenditure per person by ethnicity? Because, you know, this current government would like all New Zealanders to think that Māori are getting more than their fair share of health expenditure, and I'm just wondering how true is that?
So I could point you to a really wonderful paper by Paparangi Reid and colleagues, which looks at basically the underutilisation of primary care and the savings that are generated by the government, by Māori not using primary care. So there have been some analysis on the cost of health inequities, but that's at a population level. There's children and adults that are done as part of that research project. But I think, yeah, it would be, I'm sure those numbers exist, Lisa, and they would be obtainable.
Yeah, I'm sure they do too. Well, that draws us to an end. It's now 1:30. So thank you very much to our speakers, Kerri, Tim and Harriet, for your contributions and for the contributions that you continue to make in your mahi, and for handling the questions, some of which were very long and perhaps difficult. So thank you. And thank you to everyone for coming along today and asking those questions. I'd like to also thank all the others who have helped behind the scenes with this work, and for those who've had to chase me up quite a lot. Don't forget that you can get involved in the campaign, and the 3 things that you can do right now is sign up, and there's a link at the top of the chat, and Kate might post it again. Oh yeah, she has at the bottom there. You can fill out a volunteer form that will be sent to you when you sign up. And for those that are able to, you can make a donation to the campaign as well. And there's another link in the chat. For everyone who's attending here, we'll also email you through these links and the webinar recording, just in case you can't click on them right now. And I'd just like to let you know about the next upcoming seminar. So the Better Taxes Campaign and Tax Justice Aotearoa are hosting a special seminar on Thursday to have a wānanga in response to Labour's capital gains tax announcement. So that will be on this Thursday, 6th of November, 12:30 to 1:30. At this stage, it's online. It might be in person, and there's a link to that in the chat. And finally, the next session in this Tuesday's Tax on Tuesday series is about funding a better, the series about funding a better Aotearoa, why we need more revenue. That will be on the capable state. That will be on Tuesday, the 25th of November, 12:30 till 1:30, in person at the PSA office in Pōneke, or online like here today. So you'll see a link there in the chat. And as well, on the Better Taxes and Tax Justice website, if you sign up to the mailing list, you'll receive notifications of not only the next event, but more sessions in the future. So that's it. Thanks again to all of our speakers and to everyone who's attended today. I'm looking forward to campaigning alongside you and signing up myself to be part of this campaign for a better tax system. Kia ora koutou. Thank you all for coming.